Well, good morning, everybody. Why don't we go ahead and get started? I'm not sure if we need the mic, but we'll use it. We're actually going to try to record this session on the computer so it'll allow us to walk around a little bit and not have to shout. Good morning. My name is Gus Burkhead. I'm with the University of Albany, and welcome you all, and thanks for coming to this session on psychological first aid technical assistance provider training, and we'll explain what that's about as we get into this. You should have signed in over on your right side, and particularly if you want CME or continuing education credits for this, and grab a name tag. And then there is on the left-hand side of your folders a little pre-questionnaire. If you might just take a look at that if you haven't while I'm talking here and going through the introductions. This is a grant that we have received at the University of Albany, and just to acknowledge our funding source is the Centers for Disease Control and the Association of Schools and Programs of Public Health. For the continuing educations, we just need to make some disclosures here at the beginning. This is being done by University at Albany. Some more folks coming in. Grab a seat wherever there's a folder, and we'll get you signed in as we go along here. Sure. In collaboration with the Institute for Disaster Mental Health at SUNY New Paltz, and I'll introduce Dr. Vermeulen in a minute. And it's also co-sponsored by the University of Albany School of Social Work, which is how we're getting the social work continuing education. And we, the presenters, don't have conflicts of interest to disclose.
So when it comes up to that question on the evaluation.
The question on the evaluation about conflicts of interest?
We don't have it.
We
get that wrong in each evaluation.
Nobody checks that off. So we have an agenda laid out today going from now till about 1 o'clock. And we'll go through sort of the goals of today's session and an overview of our project on psychological first aid, and talk about your role, what we hope your role will be as technical assistance providers. Dr. Vermeulen will talk about psychological first aid. You are all mental health experts, probably experts in psychological first aid, so you probably know this, but this will put us all on a level playing field in terms of background information. And then the real, I think, core of what we want to do today is do some small group skills practice sessions. If you've participated in disaster mental health trainings with Dr. Vermeulen, may have done this already, where we break into groups of 3 and practice the skills. You probably don't need that practice, but what we're trying to do is turn you into folks who can help facilitate sessions like this with persons without a mental health background who work at hospitals or county health departments. So that's the real goal of today's session. And then we'll talk about how that went and what sort of the best ways to facilitate that kind of small group interaction is, and then wrap up and be done by 1 o'clock or maybe even a little before. So just in terms of the logistics, there are social work continuing education credits, 2.5 hours available for today's session. And if you sign with the forms and complete the evaluation form, the University of Albany School of Social Welfare will email you a link in about 5 business days for you to go online and get your continuing education form, certificate. And if there are questions or problems with that process, there's an email on this slide for you to go to. And then if any of you needed travel reimbursement today, we have the forms here. Mary Riley Hakame is the person to talk to, and we'll get your travel covered. And if there are questions about that process, there's a different email, the Center for Public Health Practice at University of Albany to go to. Okay, so those are the logistics. Let me just introduce our project personnel. Again, my name is Gus Burkhead. I'm at the University of Albany in the Center for Public Health Preparedness. Mary Riley Hakame in the back is the project coordinator for this. Mary may be known to some of you. She's been around in preparedness circles at least for quite a while, and attends the regional Health Emergency Preparedness Coalition meetings that the State Health Department puts on. And then Dr. Carla Vermeulen from the Institute for Disaster Mental Health, and also Rebecca Rodriguez up here in the front is our content expert on psychological first aid, and will be leading you through the sort of the background info on PFA, and then the process of doing the small group interactive sessions. And then we have a couple other folks on the project who are not here today, but including a student intern working on this. So what are the goals of today's session? I think you all have professional background in mental health and may also have worked in the area of emergency response and preparedness. So we want to just review briefly with you the principles of psychological first aid. And as I mentioned, really the goal is to turn you into technical assistance providers for trainings for non-mental health folks at county health departments, hospitals, and other disaster response partners through the Health Emergency Preparedness coalitions. And I'll say more about those coalitions. And the particular emphasis, as I mentioned, on the face-to-face scenario-based interactive learning sessions. As you'll see, we've developed 10 scenarios to base those face-to-face sessions on, and we'll go through some of those in the practice session. We also are looking for feedback from you. This is something that a project in progress at this point. Our real goal, overall goal of the project, is to develop a training coordinator guide for folks working at state and local health departments or hospitals to understand how they could get a psychological first aid training done at their institution or facility. And so we have developed an online, a review of all the online courses, which is a copy of in your packet, that are available for psychological first aid. And so I think our idea is that if a hospital or county wanted to do a PFA training for their staff, they could have them take an online course, hopefully a short course. There's some as short as 45 minutes, which we think are pretty good. And then arrange a session, interactive face-to-face session with the staff to practice those skills, because I think we feel that the practice part of this really cements the ideas. You can watch an online course, but then step into an emergency response and have no idea, what to do. So the practice piece of it is helpful, and that's where you all might come in if a hospital or county wanted to do a session with their staff, you could help facilitate that interactive face-to-face training with them. And there are a couple trainings coming up in the near future, and your being here today doesn't commit you to do any of that, but we hope that some of you will be able to do it, and also would be willing to stay on a list of such providers that in the future, if anyone wanted to do, sorry, there's feedback here, wanted to do a training, that you would be at least be willing to be contacted. If you can't, your schedule doesn't permit, that's fine, but I think we want to try to build a sustainable resource in the state where this kind of training could happen into the future when the grant is up. So let me just talk a little bit about the gap that we identified and what we got specifically funded to do on this grant. So psychological first aid, I think you would agree, is a core preparedness competency for response agencies, so both county health and mental health departments, hospitals, but other kinds of healthcare facilities as well, nursing homes, home care. We've had instances of nursing home evacuations needing to happen in New York from flooding or snowstorms. So you can imagine emergency response in any kind of a healthcare setting. And we have home care folks who deal with people at home, people who may need to be evacuated in an emergency. So to be able to practice the principles of psychological first aid is something that a lot of people who work in healthcare should be able to at least know the rudiments of, as well as other emergency response workers, volunteers who might be involved. And although training has been developed, it may not be those trainings may not be well known. I think back in 2007, the State Health Department made its funded hospitals and counties do psychological first aid training. That's now 9 years ago. So between staff turnover and new roles and lots of other competing things, that one-time training was great, but our goal really is to make this sort of a sustainable thing going on into the future. We're not alone in this. The National Association of City and County Health Officials did a survey of local health departments and found that they do not often have staff with expertise in behavioral mental health to even consider how to do a training for their own staff. Here in New York, our Homeland Security Strategy identified training of PFA as a need. And this project actually grew out of conversations that we had, primarily Mary had, attending the Health Emergency Preparedness Coalitions with hospitals and counties. When we knew this grant was coming, Mary went to those meetings and said, what area of training do you feel we have the biggest gap that we should apply for in this grant? And the idea for psychological first aid actually came from folks in the field, that this was a need that they felt. So we applied and we got the grant. And I think the feelings at those meetings were that people may not be aware of the resources available, particularly online resources, lack the expertise in the content, or even know how to select the right course. Even if you could find a course online, what's the best course for your own staff? They may lack subject matter experts to help with the face-to-face interactive practice, which we think is a very important part of this, but not often acknowledged, and there's certainly no guide as to how to do that sort of thing. So we've tried to develop that in this program. And some counties and hospitals may or may not have access to local mental health resources, or not know who those resources might be for the practice sessions, or even in the event of an emergency. And certainly time and resources to design a training policy. And part of this project is to try and get people thinking about actually having a policy. We did a survey of counties and hospitals, and about 8% say, well, 90-some% say they have training policies, but only about 8% had a PFA training policy. And when we asked them for a copy of their PFA training policy, many of them said, well, it's not actually written down on paper. So I think part of our goal here to make this sustainable is to sort of build this into the process of training at facilities, make it part of the routine, but also have the resources and have somebody at the facility comfortable that they could actually design and put on a training for their staff if they wanted to do that. These are the 4 health emergency preparedness coalitions that we're talking about. These are funded by and run by the state health department in each region, and quarterly they bring together all the hospitals, many nursing homes, some home care, emergency, police, fire. It varies depending on the region, but a lot of different emergency response partners come together, county health departments, hospitals, and talk. And this is the venue in which we got the feedback that PFA training was something that they felt was a need and a gap. And this is also where we're basing our subsequent trainings to this, and I'll talk more about that when we actually talk with the training coordinators at each of the facilities about psychological first aid and where we would be looking for your help. I think November 7th is in Rockland is when we're going to do the next of it, but I'll get to that. Getting ahead of myself. This just shows a little data from the Capital District Health Emergency Preparedness Coalition about the amount of preparedness training, and of course people get a lot of preparedness training, but you can see what you see on the right-hand side of this slide is a lot of people got CPR training and AED training and other kinds of training, but the PFA arrow there is pretty low. So, and this is among the people who work in the Serve New York. This is the volunteer directory that the state has put together for people to respond, to come and volunteer. And volunteers may be interacting with the public, and so psychological first aid would be probably an important thing for them to be able to know how to do, but very few have had it. So the specific outputs of our demonstration project that we're funded to do are, first of all, to identify and evaluate all the evidence-informed online trainings. Notice I said evidence-informed because we talk about evidence-based interventions. I think in the area of psychological first aid, it's hard to imagine how you could actually do a controlled randomized trial of psychological first aid or not psychological first aid and really show that it's an evidence-based. So what we refer to it as is evidence-informed, that the components of it make sense. Someone, when we came in, said, I'm a social worker and I did the online training and it's just social work 101. So that's you guys may know that stuff and feel that way, but the average person may not get it, and that's the idea here. And so the pieces of that, there are evidence obviously in social work. How you approach people and talk to people is what we're trying to get at here. And we have developed or in the process of developing a training coordinator guide that would list all the existing courses. And in your packets, I think on the right-hand side behind the slides. You get to the table of contents of that guide, and then an example of the format in which of the online courses that we have reviewed. And behind that is, so that's not, it's not the whole guide, but the listing here, this little sheet is actually all the courses that we've reviewed online, so you can see what they are. And we have a much more detail on each one of them as to who the intended audience is and the timing and that sort of thing. And then also on the right-hand side, behind that is the facilitator guide for the face-to-face training and what we're going around the state and doing, and we've done several of these already, and we'll do one on November 9th in Rockland, is to bring in the people who are the training coordinators at hospitals and county health departments and sort of give them PFA 101, but more importantly, talk to them about how they could actually do a training for all of their staff, or all the staff appropriate who might deal with the public in a crisis situation, and also have them be comfortable with sort of doing the face-to-face interactive. And I've highlighted that in red on this slide. It doesn't show up very well up on the screen, but including the face-to-face interactive scenarios, and that's with technical assistance from local mental health agencies and providers. So that's where you guys come in to that equation. Basically, once we've got this training guide in place and have sort of rolled it out around the state, until the end of the grant, which is next August, we're around to provide technical assistance to hospitals and counties if they want to do a PFA training for their staff. We'll help them. And then after that, hopefully we can hand off the list of your names to the regional preparedness coalitions so that in the future this will be sustainable. And the other piece which I've mentioned is help the agencies develop policies that will make it basically a sustainable thing going forward. So these are just graphically the steps of our process here. And actually we started out with what we were referring to as the master trainers. These are folks who've done a lot of the OMH-based training, and I think we have some folks in the room here. If you're a couple of folks, master trainers 3, who've come today to sort of help us with you to do this interactive session, and so you'll see how that plays out. But then we did 2 trainings for local mental health folks. Actually, this is the second one of those trainings that's going on. And then, as I mentioned in the big box here, the 4, and probably it's going to be more than 4, regional training for the training coordinators. And that's where, again, I've highlighted, it doesn't show up very well, the local mental health providers, you all, to help assist with the actual interactive training at those settings. And then finally, as I mentioned, we're around to provide PFA technical assistance to any agency that wants to do it until our grant runs out in August. So just again to be clear on what we hope your role will be in all this, if you're able and your schedule permits, obviously attend 1 or more of these regional training coordinator trainings and help for the roughly hour to 2 hour part of that training, which is the interactive scenario based. You don't need to come for the whole. They're 4-hour trainings because we go into a lot of background on PFA. These folks won't have had any background on it. So it's really the scenario-based part of it that we would be looking for help on. And also, I think we're interested in your feedback today or in the future on the materials and the things we could be doing better, because we're still in the process of putting this back together, putting this all together, particularly the course summary and the training coordinator guide. We've got the table of contents of that guide, and we hope, I guess, at some point we'll have this all online, and when we do get it all online, you can go look at it and continue to give us comments if you have any. And then finally, I think, and this is on your questionnaire at the end when you fill it out, if you're willing to be listed as a regional training resource for agencies in your area in the future, if they want to do a PFA training, that you'd be at least able to consider helping them particularly with the scenario-based part of it. So these are the remaining trainings that we have. Obviously, for you all, the Hudson Valley one is the one in your area. on the 7th. That's coming up pretty quickly, so no worries if you're not able. But if you are able to come, that one's in Rockland County, and we'll at the Rockland Fire Training Center, I think, on the 7th from 10 to 2. So if you're interested, when we'll follow up after this by email, to come to the part of that session where they do the interactive training part, that would be great. We're doing one in Western New York on the 17th and one on Long Island on the 30th. If Long Island is reachable by any of you, that would be you could also, if you're willing, come help us out with that one. So we'll get you the information on when and where those are. So I already had shown you the training guide. The table of contents is there, and it's hard, I guess, for you to comment just on a table of contents, but we do are starting to put together these different chapters or pieces of this. So there's a section on, and this is for training coordinators at hospitals and county health departments, this guide. That's who it's intended for, so that they could feel comfortable that they have enough information to actually arrange and do a psychological first aid training for their staff. So what is the guide and how do I use it? Some basics about psychological first aid, what it is not, and why it's important. CDC also wanted us to focus on something called getting to outcomes, which is a quality improvement approach, and so we do a little bit of that in the training, and there's some background information about that in this. If you're interested in quality improvement, it's a nationally known quality improvement process that is used a lot in public health anyway. So you might want to take a look at that. Then the document that reviews all the online courses that we've looked at, and we've done that, actually Carla and Rebecca did a lot of that review, and it's very systematic in terms of trying to see who the intended audience for these different courses are, how difficult is it to go online and do it. Some of them are difficult to sort of enroll and get into. Does it cost anything? So things that a training coordinator might want to know in selecting a course. Some of them are focused on, a particular radiologic disaster or some other kind of disaster. So there are lots of different courses out there that we've reviewed, and have that what you see there is really just sort of the table of contents of that whole document, but it shows you which courses we've looked at. If you're aware of a course that's not on this list, let us know, because we're trying to make this as comprehensive as we can. And you see here also that we've looked at things like the content level, beginner, intermediate, etc. Some of the courses are 6 hours and are intended for people who have probably mental health background or really want to get into it. Others are much shorter, probably more appropriate and feasible if you're trying to get a lot of people trained up on a course. The University of Minnesota has a good course that's only 45 minutes, so that's the kind of thing that probably you could get a lot of staff to do. Unfortunately, they've started to charge for $10 for it to get a certificate, so that's a barrier. But so that kind of information, though, is hopefully helpful to people in picking out a course. And then the other piece of it is the facilitation of the interactive scenarios, and there you do have on the right-hand side the full packet, I think, of that facilitation guide, and we'll go through that in some detail today, so you get a sense of that, because that's really what we're hoping you'll be able to help us out with. And then we are in the process of putting together other resources. There are lots of webinars and other kinds of videos out there on YouTube about psychological first aid, which really aren't trainings, but they might be helpful to somebody with a specific need of a particular population to fill. So we'll have hopefully a pretty complete listing of those kinds of resources that are out there. Some training tips. We will try to be developing some policies around PFA training. I don't think a PFA training policy is necessarily rocket science. It's, who does the policy apply to? How often should it be done? Which training to do. So, but we want to try to work through those issues. Even if you've had psychological training, first aid training 5 years ago, there may be a refresher that's needed. You need a way in a hospital or county to pick up new staff that are coming in and be sure that they get trained and on some kind of a timetable. So policy would be a fairly, hopefully simple outlining of how that should work. So we're working on that piece. Evaluation, if you're going to do a training anywhere, you should probably evaluate it in some way. So we'll have evaluation tools as part of this training guide, so that people can evaluate whether they're meeting their goals, and really as part of an ongoing quality improvement around PFA. And all these principles really could apply to any kind of training you're going to do. You should probably have a training policy, figure out who should get the training, evaluate the training when you do it, and hopefully these tools will help people more broadly than just PFA. This is the thing I've been waving in front of you here, really the table of contents for the review of the online courses that shows you a brief description of the target audience, the duration, the content level, and a brief summary of it. And the Minnesota course, which I mentioned, and I think we suggested that you might want to look at, is number 2 on this. So if you have comments, if you did do that course and have any comments about its appropriateness, or we've had people say that it's a difficult one to sort of sign up for and get into, but just the logistics of it is some people have had trouble with. So any kind of feedback like that would be helpful. Or if there's another course that you think would be better for us to recommend more widely to people, let us know. We're looking really for any kind of feedback you have, and what kind of equipment do you need? Do you need any special, apps or anything to look at it? Actually, there are some apps also out there that you can download on your phone, which are sort of refresher or just in time, so we review those as well. University of Minnesota, again, has a nice app that you can put on your phone, so if you suddenly got called to an emergency, you can at least pull up the basic principles of PFA and review them quickly. So that kind of thing does exist also. Okay, so I think I'm now going to turn it over. We have to choreograph this to Dr. Yuen to talk a little bit about PFA quickly with you, and then go into more detail on the facilitated part of the session today. So Carla.
All right.
Thank you.
Thank you. All right. Hi, everyone. Oh, this is feedback. Oh,
Yeah, just hold it a
gotta
little
get
bit far away.
used to this. All right. Sorry. I hope I won't shock anyone. So yeah, I see some familiar faces from IDMH events and conferences and OMH trainings and all of that. I'm with the Institute for Disaster Mental Health, and we've been doing a lot of trainings around the state working with Office of Mental Health, Department of Health, et cetera. So we were very excited to be invited to participate in this project because we just have this philosophy that it's important to train people in disaster mental health specifically, but that is intended for mental health professionals who, of course, are a very small minority of the people who are actually going to get involved in any kind of disaster response. So, getting PFA out there as widely as possible is kind of a mission that we've been working on, and I think this, getting it out to healthcare and public health is such an important part of any response. So it's been great to sort of be involved in that. So I'm going to go through very briefly. Now, how many of you have taken a training in PFA? Okay, so not everyone. Okay. And how many of you actually did the online course? A number did. Okay, great. All right, so I'm going to just very briefly review PFA. Again, the intention when you are serving as the technical assistance providers for these trainings, the intention is not that you teach people PFA. The assumption is that they will have taken an online course or something. So your goal isn't to teach them in the basics of PFA, but to, as Gus was saying, support the interactive practice exercises. But it may be necessary, kind of depending on the audience, to kind of do a little refresher review. So what I'm going to do here is sort of an example of the kind of level of detail you might want to get into with people. We have been training the training facilitators in more detail on PFA, and the assumption is that you would be working with those training coordinators and kind of figuring out sort of what your role would be. So I think, the intention is that the training coordinators would be the ones really overseeing it, and you would be providing the guidance on the exercises. But we would hope you would be flexible. Some of them might need more support, more attention from you. So I'll kind of get into what those specific roles would be a little bit down the road. But basically, just quick refresher on PFA. It is an early intervention. It can be done immediately after a disaster, or really after any traumatic event, not just disasters, which is another reason to kind of get it out there widely. To me, PFA is sort of not so much things that you do, but almost more just an attitude that underlies every interaction you might have with someone who's been through something difficult and traumatic. So it is, yes, it's really aimed at stress reactions, at those very early reactions, often when the person is just starting to absorb what they've actually been through, starting to come to terms with the amount of losses they've experienced, etc. It certainly can be used with the responders as well. It can be sort of part of self-care, but it's not just for the victims or the survivors. It can be kind of applied to anybody who gets involved in the response. And it is certainly the good analogy related to medical first aid, where we encourage people to get the training in basic first aid and CPR, et cetera. Anyone can learn to kind of do that kind of thing. You do not have to be a mental health professional to practice first aid, but part of that is also knowing the limits of where your training in first aid ends, and someone really does need the assistance of a professional. Exactly parallel with psychological first aid. All of us can do that kind of supportive early response, but part of it really is training people to recognize, okay, this person needs more than I'm capable of giving them, and how do I do that? How do I make a referral? How do I hand them off to a professional? And as Gus said, we described as evidence-informed because you really, the whole premise of PFA is that it's so flexible, it's not manualized, it's not meant to be applied in the same fashion with everyone. It's meant to be a toolkit of things that you can do for a person, which is great. I mean, that's its strength, but that also does mean that it's impossible to say, well, if someone gets, three psychological first aid interventions, that will reduce their likelihood of developing PTSD by 45%. It doesn't work that way. Human beings don't work that way. So we can't sort of say it's evidence-based, but what we do know is this was a kind of landmark article that's almost 10 years old now, but this was written by 20 of the world's top trauma psychologists and psychiatrists. So it's sort of an international group. And what they did was they looked at all of the published literature out there and also included their own experiences as responders and helpers. And what they were trying to do is identify what are kind of the themes that underlie early interventions for trauma. And they found that these were sort of the 5 principles that seemed to be the most important. So promoting a sense of safety, absolutely clear that until people start to feel safe, they can't start to process what they've been through, they can't start to recover from it. And often it's not clear, part of that is the event over? Is it really done? Am I still in danger? Is it going to happen again? Unfortunately, sometimes we don't know. Earthquakes have aftershocks, terrorist attacks often have follow-up attacks, things like that. But basically kind of helping people to feel as safe as possible so that they can then start to, again, process what they've been through. Certainly closely related to that is promoting calm. You go through a frightening or traumatic event, it activates your physiological arousal, that fight or flight response, and that takes a while to come down from. People literally have kind of a stress hormone hangover for a while. And it's also, when you have a collective event like a disaster, people pick up on each other's emotions. Often this situation is chaotic, and people are kind of feeding into each other's anxiety and each other's distress. So one of the important roles for the responder is to try and bring that down. And basically by being calm ourselves, often that can kind of lower the arousal level with everyone we're working with. So that's certainly very important. Then the efficacy part, that is basically kind of reminding people that they are not powerless victims which often after a disaster, that's how it feels. You know, you've had your sense of control taken away by what happened, and so what the responders need to do is try and restore some of that sense of, you are not helpless. You can help yourself. You can help your community. You can kind of have again, just that efficacy, that sense of control restored to you. Another one that is super important and that we can't emphasize enough is that restoring connectedness. Is very clear that people's natural sources of social support are the most valuable assets in recovering from a disaster. Now, unfortunately, some people didn't have a social support network before. Some people were sort of isolated to begin with, or maybe they did, but that's been destroyed or impacted by the disaster itself. So some of what we want to do is connect people with their friends and family and neighbors, but if that's not possible, the responders can kind of fill that role, at least temporarily. And then instilling hope. If you've lost everything, it's very easy to feel like you're always going to feel like that. And so trying to restore some sense of hope, not hope that it's going to be exactly the way it was before, not hope that you can make the whole thing go away, because that's not an option, but just hope that things will get better, that you will be taken care of, you will feel better someday. So again, very basic stuff. I mean, I love whoever described this as social work 101. That's a perfect description for PFA. But this is kind of those principles that underlie what we do in terms of PFA actions. So what are we trying to accomplish with this? Basically just taking those principles and putting them into action. So what we'll see with the elements is just, how do we actually do that in order to help people feel safe again, bring down that arousal, help them feel calm, give them that sense of efficacy. All of the principles I was just talking about, how do we actually do that? And a lot of it really is very practical. I mean, when we teach PFA, we always talk about working Maslow's hierarchy. So, if someone is cold and wet and hungry, they are certainly not going to be able to start thinking about anything until they are dry and clothed and fed. So literally giving someone a bottle of water is a mental health intervention if that's what they need at that time. Really, this starts very, very basic, and it stays pretty basic. I mean, with, thinking about Maslow's hierarchy, we kind of go to like the third level or so. We're not thinking about your self-actualization. That's not PFA. That's something else. That's important, but that's not what the person needs right then. So what we teach people is just, the person in front of you, what do they need, and how can you help get that for them? So it is certainly not therapy or counseling. It is very immediate. This is not case management. It's entirely possible and very likely that all of your interaction with this person might be a 5-minute conversation, or that might turn into an hour-long conversation. But you basically assume that this discussion you're having with them is likely the only time that this is your one shot. We are looking at, again, just reducing their symptoms in order to kind of reactivate the natural resilience and natural recovery processes. We are certainly not delving into their relationship with their mother. That's not what we're interested in at this point. As I said, very practical, very basic stuff. And it is universal. Anyone can learn to do it, and it can be done with anyone. It can be done with children, with responders. There's no barriers on this. It really should, the more people we have who are sort of prepared to do this, the better. So briefly, I'll just go through these quickly. One of the things that we always try to emphasize in training trainers or people to teach this or expand on this is there are a whole lot of different models of PFA. The Red Cross has its own model. The Office of Mental Health has its model. National Center for Post-Traumatic Stress has its own model. All of them are consistent in spirit. They just describe them in different ways. There are different numbers of elements. Sometimes describe them as actions. So sometimes that throws people a little bit because it's possible that if you're supporting a training and they've taken one of the online courses that we've recommended, that might sort of give them a specific list of elements, and then they come in and we're having them do an exercise using a slightly different list. One thing is just to say, yes, it's slightly different, but it is consistent in meaning and spirit. If for some reason you think that's really going to throw people, you could always alter the list of elements that are on the worksheet that we'll come to. So that's certainly an option as well. But this is the set that we've been doing with the Office of Mental Health, and I think it's just kind of a good basic, combination of elements. So what are we talking about with this? So making a connection. How do you start the conversation with someone? You see someone who's very distressed. How do you enter that person's world? And that seems like kind of an easy thing, but if that person is very upset, that person is crying, that person is staring into space, that person is angry, how do you sort of do that? And this is another one where we come back to, tied in with the physiological needs, often that offering them a bottle of water or a cup of coffee, that can be a great way to sort of make that initial connection. You introduce yourself, you say what your role is, and maybe you just ask how they're doing, and hopefully it kind of goes from there. Physiological needs, I think that's pretty straightforward. What do they need in terms of clothing, shelter, food and water, etc. The safety needs is a little trickier. Certainly that could be physical safety. Can you try and prevent someone from going into a house that's been severely damaged, but they want to get in there and check on their possessions and find their pets and things, but are they putting themselves in harm's way? Is that something you can kind of talk them out of, maybe? Also, probably more important, not more important, but equally important, is the kind of emotional safety. Is the person standing in front of their destroyed house, staring at it, fixated on it? How can you kind of, break that sort of trance they're in, even if that's a matter of kind of turning them around so their back is to it, so that they can start talking to you and you can start seeing what they need. The acknowledgement, recognition, and reassurance, this one I think is interesting because we always want to think about disasters cause this kind of spectrum of losses. It's even if everyone in a community goes through the same weather event, say, certainly they're not going to have the same amount of losses. They had different resources going into it. There's going to be different amounts of damage, and so on. And so you get this kind of balancing act where you certainly want to validate the extent of the losses people have had. You don't want to minimize them. Sometimes people will minimize it themselves. They'll say, I didn't have it so bad. I lost my pets, but my neighbor lost his whole house. There's a difference there in that the extent of those losses, but you lost your pets, and that's a terrible loss, and you have the right to mourn that, just as your neighbor has the right to mourn losing his house. So you don't want to over-exaggerate it. You don't want to dwell on the negative side of it, but you certainly do want to kind of validate and let them express what it meant to them. Remaining calm, I talked about this before. When we're talking to people, it's so easy to pick up on their emotions and start, so we start mirroring their anxiety when what we need to do is stay calm ourselves so that they start mirroring our calm. I always find I can tell in myself when my breathing starts changing, when I start sort of breathing shallow and fast, that I'm picking up on those emotions. So kind of making myself calm my breathing down and slow down in that way. And I will also say that can be remaining calm in the face of anger and extreme emotions. We'll come back to this in the exercise, but certainly people who've been through a disaster, many of them are sad and distressed. Many of them are pissed off, and they're going to take it out on whoever is there. So remaining calm in the face of that, understanding that it's not aimed at you, is very important. Providing warmth, empathy, and genuineness. You can't fake this. You have to genuinely be supportive and understanding and want to help the person and not be treating them as a powerless victim, but treating them as an adult with agency who just has been through something terrible. And with this one, I always think the roles could have been reversed. It just as easily could have been me who went through this. And how would I want to be treated if someone was talking to me in this regard. Empowering the survivor. I hate the word empowering, even though it is, I like the meaning of it. It just sort of becomes so cheesy. But, what can you do to restore that sense of efficacy and agency for them? Some of that can be encouraging them just to make some basic decisions. We have a colleague who was formerly with the Red Cross who taught us what we call the lemonade rule. She said what she would always do is, she's trying to make that initial connection with someone, and she starts off by saying, would you like some water or some lemonade? Because that forces them to make a decision, right? It's a meaningless, they're not going to make a wrong decision on that regard, but it does just give that sense of, okay, I am not just here having something handed to me with no say in the matter, and maybe that small act can start kind of kickstarting that, oh yeah, you know what, I'm a functioning person and I can do that again. Information, that's why we've got 2 points on this one. Information is what people are desperate for in disasters. Is it over? What happened? Are we safe? When can we go home? How much money is FEMA going to give me? How do I fill out these insurance forms? It's all of these different kinds of information. Some of it sort of existential, some of it just very practical in nature. And so certainly what responders need to do is figure out what information can I access and how can I verify that this is true. That's why we have the providing accurate information. You absolutely don't want to be speculating. And you have to be comfortable saying, I don't know, because there's a lot of uncertainty after disasters, and that is really frustrating for people. Well, why don't you know? Why can't you find out? Where is my loved one? What aren't you telling me? So again, saying, hopefully you're saying, I don't know, but I will try and find that out for you, or I don't know, but I do know that there's going to be a briefing at 5 o'clock where the mayor's going to give more information. Giving them something, and sometimes I think just saying why you don't know or why you can't reveal something helps kind of justify it. It's not just we're keeping something from you, it's that we haven't had these reports yet, the situation is changing, etc. The social support, I talked about that. Is there someone you can call? Do you want to borrow my cell phone? Do you know their number? How many of us know phone numbers any longer? That's a challenging one. So can I help you find the phone number? And also making sure that they're accessing positive social support. You don't want to be encouraging someone to call their mother when their mother's going to say, well, I told you not to marry that jerk. You never would have been in that neighborhood if you had listened to me. That's not positive social support. So we definitely want that. And sometimes people will resist, well, I guess I could see if I could stay with my sister-in-law across town, but I don't want to be a burden on her. And that in that case, it's often a good, well, if the roles were reversed, would you want her to call you? Wouldn't you be there for her? Making a referral, and that is, in a way, this is almost the hardest thing to sort of teach a lay audience with PFA. How do you recognize signs that someone really does need professional help, and what can you do with that? And that we basically say in training the training coordinators, you just need to know what that would be in your particular setting, in your agency, and communicate that. We can't sort of give a blanket, advice on what that would look like, but encouraging people just to recognize, okay, if you are feeling this is beyond the limits of what you're comfortable doing, don't just walk away from the person, but hand them off to someone who you think is going to be better able to help them. And then how do you extricate yourself from the conversation? Maybe the person has just told you something very powerful and emotional about what they've lost in the disaster, and it's hard sometimes to get, to sort of gracefully leave that. Again, if possible, you want to leave them not alone, with someone else, whether that's someone they know, with a mental health professional, with a clergy member, whoever might be a source of comfort for them. But that can be difficult as well. So that's kind of the brief overview of PFA elements. I mean, these all, again, we know they're total common sense, but the other standard line in this is, in disasters, common sense isn't common. It's so easy to just, things that we would normally do automatically or would just do for a friend, because we're in this chaotic situation, or it's overwhelming, or we're feeling helpless, we're feeling like we want to fix it for people and we can't, it gets really easy just to lose sight. So that's why we train people in PFA, so they have this kind of toolkit. And it's a great idea. There's a lot of resources out there like wallet cards that just list these elements, apps that are a great refresher as well. That's a new development. But encouraging people just to, have something that can just remind them. So if they're feeling sort of, they're clutching and not knowing what to do, have a little cheat sheet and think, oh, okay, here's maybe what I can do for this person. All right, any questions, comments? Pretty basic? Okay. So now I will focus on really how you could help with delivering these trainings. So again, this would be, you would not, in the way we're envisioning this, you would not be running these trainings per se. You would be working with the training facilitator, training coordinator at the site. So you would be kind of brought in as the subject matter expert. And it's really going to be up to the two of you, kind of how extensive your role would be. So we've trained those coordinators to actually lead this, but we're going to train you in that as well, kind of as backup, even though you might not actually be doing that role. All right, so first of all, why this emphasis? I think Gus has mentioned this a number of times. You can take a training, you can listen to my little spiel on PFA, but it feels very different when you are suddenly in this situation, dealing with the emotions, and there's my common sense line, how about that? And so we really emphasize that need to practice it in controlled circumstances, in a safe environment, where people can kind of say the wrong thing and learn from that without it having consequences with an actual survivor. And also the way that we've set up this exercise, we have people act as the survivor, as the victim, as well as the helper, and then as an observer as well. And I think that can be just as important, to be in that role. Like, we're all helpers in this room, right? We know how to do that. But how often do we kind of step back and think, oh, wait, now I'm on the other side of this. What actually is helpful, and what assumptions have I been making about what would be helpful? So that's our rationale for really emphasizing that in-person practice component. So actually, what I suggest, you've got in your packets both the facilitator guidelines and the handout with the scenario. So I suggest actually pulling that out and kind of following along with me. So the basic way that this works is we've got a number of scenarios, and I'll talk about those in a second. We will be splitting people into groups of 3, and so client, helper, and observer. And what we tell them to, when it's the real practice session, each group will spend 10 minutes on one scenario, then 5 minutes just talking about it within the group, and the observer in particular sort of giving feedback during that, but also the helper saying what they thought helped, and the client saying what worked and what didn't work, basically. Then they rotate, and then after all 3 of the scenarios have been done, people will come back together and have a large group discussion about the process led by the facilitator, or possibly by you, or you chiming in with the facilitator as you all decide that. So the scenarios, we spent a lot of time and got a lot of feedback developing these. And basically you can take a look at these, but each one has a brief description of a specific setting, scenario, disaster situation, and then some suggested client statements. So basically we've got, a lot of these are healthcare oriented, just given the nature of this project, but they're looking at very different kinds of events, very different kinds of settings. We have one nursing home evacuation and some of the consequences of that. We've got a point of dispensing, so there you've got sort of public health and all the anxiety that's associated with that kind of setting. The infectious disease outbreak, in that one, the client is actually in isolation, and so the PFA intervention is being done over the phone, which is certainly something that could be realistic and has a lot of challenges. There's a school shooting where the scenario, you'll see it, but so there's a shooting, and the client is basically the mother of a child who witnessed her friend being killed. That one's very intense, might not be appropriate. A lot of people have a very strong reaction to that one. I'll come back to that point in a second. The hospital-based responders to the mass shooting, so that one is in a hospital, but the premise is that the client is actually a nurse who got called into the response to a mass shooting. And so it's sort of, she was responding as a professional and now is feeling the consequences of that. So basically what we say to the coordinators is that they should read through all of these and pick the 3 that are most appropriate for their specific audience. And that is going to depend on what the setting is, is it hospital-based, is it other, and also who are they training. So we very much emphasize that some of these are going to be harder for people to deal with than others, and those should be avoided if they think that that's going to be a problem. There should be plenty of other options. But for others, they maybe have more of people, with that mental health background or emergency response background, and so it may be appropriate to kind of do some of the more intense ones for them. But basically, you might be working with the coordinators on selecting those scenarios, or they might have done that for you. Okay. Then this would be the guy, really the role of the training facilitator, training coordinator, but basically they would be preparing the materials in advance, and we've given them very explicit instructions on that, just because the logistics of putting people into groups and handing stuff out tends to get a little chaotic in itself. But setting those up, and let me go back to my, okay. Right, and as you see in the guidelines, we do include that sort of note to say, even if these are not exactly the same elements, they are consistent in spirit. So just making that explicit to people. Then I think this is important just as a little, again, refresher, or just to give people people love do's and don'ts, it seems. So these are outlined in the facilitator guidelines, but we do recommend kind of briefly going through these just to get people sort of in that mindset. And these are things that we have seen in using this type of exercise a lot of different times with a lot of different kinds of audiences. These are the sorts of things that we often see people making, I don't want to say mistakes, but falling into some of these traps a little bit. There's often this really intense drive to say to people, it's going to be okay, and you can't say that. That over-reassuring thing, it's so understandable. We want to make it better for people, but whether that's saying something like, everything's going to be fine, it's going to get back to the way it was before, that's not true. FEMA's going to pay for all the expenses to rebuild your house, that's definitely not true. So, whatever it is, it's understandable people want to make these statements, but encouraging them just to be realistic. And that also goes back to that I don't know thing. It's okay to say I don't know if you're explaining why you don't, or when they might be able to know. I touched on this before, that idea of this kind of spectrum of losses. I'm sure none of you would ever say, well, you were lucky. You should have seen how the last guy I talked to had it. But, people sometimes blurt things out like that. Or sometimes that could be, well, this is maybe an over-reassuring, but saying, well, it was God's will, or God never gives you more than you can handle, or, platitudes like that really generally are not helpful in this kind of situation. So you do want to, again, validate their losses, validate their feelings, even if maybe to you it doesn't seem as bad as other people had it, but it's still their bad. And so we have to acknowledge that. And then the next two, it is, especially for non-mental health people, developing that comfort with silence or just staying on a difficult subject is incredibly difficult to learn. This is getting overwhelming for me as the helper, so I'm just gonna try and shift or just being with someone who is being silent. You know, sometimes it's just that compassionate presence that's what's needed, but that's really hard to maintain. So just trying to learn to do that. And that's another reason why practicing is very important. And then I mentioned this before as well, that taking the frustration personally. I'm sure we've all been there where someone is targeting anger at us, and we know intellectually it's not really aimed at us, but that doesn't necessarily make it easier to take. And especially with a disaster, you might have a whole bunch, you might have a whole shelter full of people who are taking it out on you. So just trying to calm down with that and take breaks and ventilate to colleagues and that kind of thing is very important. So if you have the time and the capacity, and we really recommend doing this, and this would be certainly something that as a technical assistance provider, you would be the perfect person to do this. But give an example of a role play, model it for them. We got a lot of feedback in sort of the earlier versions of these trainings that people really wanted that. So because we care about you, we're now gonna do that, right? And I will say, as uncomfortable as people often are doing these exercises just in the small groups, it is a lot worse doing it in front of an audience. So, but my colleague Mark has graciously agreed to. And Rebecca, so Rebecca's going to act as our observer. I am going to act as the client, and Mark is going to act as the helper. And what we're going to do is the Disaster Recovery Center. So basically, when the groups are doing this in their small groups, the person who's acting as the client will read the scenario description to the entire group, and then they have these lists of suggested client statements. Those they don't show to the others, but those are just meant for them to sort of be prompts. It's not meant to be a script. These are meant to be, a suggested thing. I will say something. I will see how my helper responds to me. We will follow that conversation as appropriate. I will move on to the next one as appropriate. All right, so this scenario is a disaster recovery center has been opened after a powerful hurricane flooded entire coastal communities, displacing thousands of people. It's now a week after the storm, and the demand for services means clients must wait for many hours in a hot, humid gym in order to begin the process of filing claims for benefits. Tempers are short and rumors are flying about unfair distribution of resources. The client is an older man in a FEMA vest who is pacing around the staff break room and muttering to himself. Okay, I'll put the mic down for this. I think I'll be okay with that.
So you're the older man.
Yes, I'm the older man in the FEMA vest. Yes. All right. And normally people will be doing this just seated, you don't need the action element, but we'll go all out for it. All right. Again.
Hi, my name is Mark. How can I help you? I see you're having a little bit of difficult time.
Hi, Mark. Yeah, I'm older man in a FEMA vest.
Older man in a FEMA vest. Would it be okay if I call you Carla?
Absolutely. Sorry. So I took this job so I could try to help these poor people, and all they're doing is screaming at me.
It must be really frustrating having people yell at you and scream at you when you're trying to be helpful. I saw that you're pacing back and forth. Can I get you some water, some coffee? Is there something that I can do to help you?
Yeah, water would be really great. I've just been working all day, and I haven't been taking care of myself. And thank you. I'm doing my best, but there's just so many of them, and the paperwork case for each case just takes forever to complete, and I feel like it's my fault. If I could work faster.
I know it's completely overwhelming. Whenever we walk into an environment like this, we're often faced with lots of emotions, and it can overwhelm us, even those of us who are really trying to help.
Sounds like you've been there.
A few times. And I really have to tell you, you've been doing a great job so far.
Thanks. I'm trying, but there's so many of them, and I just feel like I can't keep up.
Are there other people that we could talk to? Is there a supervisor that we could talk to perhaps see if we can either alleviate some of your workflow?
Please don't tell my supervisor I said any of this. I don't want to lose this job.
I understand that. Must be really frightening. So what do you think we could do together in order to get through this?
I mean, honestly, even just letting me ventilate like this a little bit is helpful. I
Tell me a
appreciate
little
that.
bit more about what's going on.
We'll end it there, but you get the picture. So basically, they would spend sort of 10 minutes on that, and then 5 minutes in the small group with primarily the observer giving feedback. So Rebecca will.
Right. So as the observer, you want to kind of lead that 5-minute discussion, and so you can start by, you've got your list you've been filling in certain actions. So I'll start with the list. You started off with some acknowledgement. That must be really hard with people screaming at you. Your sort of warmth and genuineness. I thought like the use of we, like just the we part. We're in this together with your colleagues. That was great. Empowering. You've been doing great. You try to connect her with social support. And then talk. Is your supervisor available? So you go through that list. It's important to know that you don't have to, you're not going to hit all of the buttons. So to say, well, you didn't really provide accurate information in that. It wasn't necessary. It wasn't needed. So I wouldn't hamper on that too much. It's just a guide, the sheet that you have. And so then we talk a little bit about, how did you feel as the helper? How did you feel as the client? Was there anything he said that was really helpful that made you say, oh wow, that would be really useful? Did you ever feel stuck at any point? Did you ever say something and wish you immediately could take it back?
Okay, just calm down.
So yeah, any questions on that part?
How did you get him to agree to be the helper?
I'm telling you, good colleague. You stepped right up.
So whatever you need me to do.
Yep.
Great job.
Thank you, Mark. Appreciate it very much. Okay, and I think part of it is also sort of acknowledging sometimes you do say something dumb, or sometimes you break character, and that's going to happen. But encouraging people to kind of get back into it and try and stay with it and try and be serious about it is important. Not that I modeled that particularly well myself. Okay, so then just the logistics is always honestly the hardest part of this, because what you're doing, you're moving people around, you're forming groups, and this is sort of where it starts to get a little bit chaotic. So okay, we have in the facilitator guidelines that we really want to point out to people that some of these scenarios may be challenging, and it's kind of that balancing act where sometimes people might not want to participate because it's triggering for them, it's bringing up something too emotional. We certainly need to respect that and be sensitive to that, but we don't want to let people use that as an excuse not to participate just because they don't want to do the exercise. So you want to really encourage people to participate, give them that background of why the practice is so important, all of what I was just talking about, doing it in a safe environment. But if someone wants to sit it out, maybe they'll at least be an observer, or it might be that one of the scenarios that in the group is too difficult for them to do one of the roles, but maybe they'd be okay being the observer for that. So just, playing that by ear, but being aware of it. Then in terms of forming the groups, some of the things that we've developed in doing this a bunch of times is, first of all, it's really good to encourage people to work with people they don't already know. Often if you have a bunch of coworkers, they're going to want to stick with their buddies from work already. And first of all, that robs them of the opportunity to sort of meet and interact with someone new and make a new connection. But also, people just don't take it as seriously typically when they're with friends than maybe when they're with a stranger. So that would be something that the coordinator might be more familiar with. What is the makeup of that audience? But just having a plan for that is good. If you know that you have people with different levels of experience, it is great to sort of sprinkle around the people with more experience. So there's one per group or something like that, and have them act as the helper in the first scenario so that they can sort of model it for the others. Again, you might not know that, but it's something recommended. And just having a plan for how you're going to divide the group up. We've done it sometimes where you have people count off because that's sort of, and then all the ones go together, the twos go together. That's a good way of randomizing it if you're not intentionally forming groups. But when you have a larger population, that gets a little unwieldy once you're beyond, 8 or so trios. So it's always just what's going to work, what's going to be the most efficient. And we definitely recommend spreading out whatever the space allows. In this room, when all of you are talking at once, it is going to be impossible to hear or focus on what is going on in your group. So if that means moving out into the lobby, whatever the setting might be, but, giving people kind of that permission so that they're not distracted by what's going on behind them. What else? Oh, right, and, we do this in groups of 3. Obviously, numbers might not work out perfectly with that, so you could either have a group of 4 where you have 2 observers, or you could have a group of 2 where you don't have an observer and people just give the feedback. And then, of course, they have to sort of adjust the timing with that. All right, so then getting into this. So basically, this is just kind of our visual on how to switch roles. That always seems to confuse people. And frankly, I find the hardest part in leading this is just keeping people on consistent timing. Inevitably, you're going to have some groups that are going to sort of rush through their first one and move on to the second one. You never seem to have people who are going longer than that, but that is certainly an issue. And then just giving the cues for when it's time to start discussing the first one and then when it's time to switch roles. It just can be hard once people are actually talking. So sometimes I've flash lights on and off. It's very kindergarten, but it does get people's attention. Sometimes it's a matter of just literally going group to group and saying, okay, move on to the next one if you haven't. So again, you just sort of got to play that by ear depending on the size of your group. All right, and then basically if you go to the instructing participants section of this, I just recommend reading these really carefully, sort of rehearsing it, practicing it, because it's easy to kind of lose control of the group. We do suggest giving the instructions before you give them the handouts, because otherwise once people have something in front of them, they start reading, they tune you out, and then they've lost track of the instructions. So you do want to tell them, remind them there will be the large group discussion at the end in case they want to take notes or make a mental note of any points they want to discuss in that part. Tell them that the client will read the scenario out loud, and those instructions, as you saw, are on the scenarios themselves, but just point that out. And that point that I made before, that the client statements are not a script, but guidelines, suggestions, etc. And you can also point out that for the helper, it's the observer who's going to be writing things down on this worksheet, but this also can be that kind of cheat sheet for the helper, just to remind them of what some of those possible elements would be. However, again, they're not going to use all of those elements, but so they shouldn't be focusing on this thinking, oh my God, what am I going to say next to attend to safety needs, but just to glance at it occasionally, but really try to stay focused on the conversation, stay with the conversation, and for everyone to try to stay in role. And okay, so that is basically it. So at this point, we will now...
You mentioned the over-dramatic...
Oh, yeah, thank you. Wait, do I actually have it for... Okay, wait, sorry, yeah. So, yeah, just to right, we'll talk about this more later as well, but sometimes people get very overly expressive to the point of hysteria almost. That is not helpful. You want the client should be realistic. They should be emotional to whatever degree would be appropriate. But if you are so emotive that your helper can't help you, that's kind of defeating the purpose of the whole exercise. So be realistic, and also sometimes that emotion might not be the sadness. It might be the anger, or it might be the kind of flattened numbing as well. I mean, that certainly is something we often see, especially shortly after a disaster. So that can be realistic, and going back to that point about the silence, that can be really challenging as well. So, yes, thank you.
And I think just the other thing to mention is we have the 3 folks here today.
Yes, thank
Mark
you.
and the other 2, so they'll sort of you guys can sort of hover around and be there, listen in on the groups and contribute as well.
Right, right. So when you guys are functioning as technical assistance providers, you would be doing this kind of going from group to group and just providing feedback, kind of circulating, moving around. You know, if there were enough of you to stay with the group for the entire time, that would be great. That's probably not very realistic. What you will be doing when this eventually gets out into the communities, that is going to be done by the 3 people who are sort of our master trainers from the Office of Mental Health Training. So we have Marvella, who just stepped out. She'll be back. And Sherry, you're Sherry. Hi. Thank you. Thanks for helping. So they'll be doing that. They'll be kind of going and just kind of sitting in with you so you get a sense of what you'll be doing ultimately. Is that clear? Okay. Now chaos breaks out.
We have, I think, 24 people, so maybe we could just do a count off, an 8 count, and then the 1s, the 2s, and the 3s can all get together. Does that make sense?
Sure. Is that okay?
All right, and
Or
let them know, we're gonna hand out, so don't take your own set with you, we're gonna hand out a set you can use.
Right. And with that, we are using all 10 of the scenarios, or I guess 9 of them because we modeled the other one, just so you all kind of, I don't know, essentially we're still pilot testing them. So if you have feedback on any
Feedback on
of
the
them,
scenarios also
Right.
helpful.
right. But normally each group would have the same 3. But so that's a little bit different than how it'll be done in the field. So, okay, so again, yeah, I mean, if people are okay with kind of getting up and
or you could just-
moving around.
Or they could just sort themselves out.
I mean, how many of you know each other? We don't have the working with a few people, but not right. Yeah. Well, we're gonna separate
count
it.
off, because I think that's the best way to do it. Walking into a hospital, walking to a place with his colleagues, I think
Right.
to replicate what it is you think is the best way to work.
Okay, that was great. So the thing that I find challenging with the counting off then is like where each group, groups finding each other, but that will be absolutely fine. And again, moving out into the hallway
All ones
is
meet there, yeah.
right,
yeah.
exactly.
Yeah.
All right.
So if you're moving out in the hallway,
So why don't we have 4 groups? I don't know how much room there is out there. Maybe we could have a couple of groups. One
yeah,
and,
and we'll
1
come
and 2
find
can
you.
take their chairs out and do it out there, and 3, 4, 5, 6, 7, 8 can be in here.
Okay.
Is that,
you
Sure.
could just stick the tables and stay in your table area.
The only thing
you
is
could do
you,
that.
well, you can stay with your table people, but again, you're going to want to spread out just because you will not be able to hear each other once everyone starts talking. But if maybe that's simpler, just to have people.
Or you can just take chairs.
Right. I mean, people can come up here.
Pretty
Yeah.
empty out there.
Okay. So, see, this is what I said about having a plan. We're modeling what not to do. In this.
Yeah, exactly.
All right. Sure. So let's do the count off thing, and then groups can kind of decide for
Why don't
yourselves.
we just start here, count up to 8.
1, 2, 3, 4, 5, 6,
7.
8,
2, 4, 5,
6,
7, 8,
1,
2, 3, 4.
5,
7, 8.
Perfect.
Numbers were perfectly. That's impressive. Okay.
So why don't we have the 1s in this corner, the 2s in that corner,
Okay.
maybe the 3s in the middle over here, the 4s back in that corner, the 5s back in that corner, the 6s here in the middle, and 7 and 8 out in the hall.
And then we will find you with the handouts. Oh, and one more thing. Sorry, I should have said this. Normally, we'll do the 10 minutes and 5 minutes. For you guys, we'll do like 7 minutes and 3 minutes of discussion, just because the point is not so much for you to really practice the PFA, but to get a sense of what the
but we're
exercises are.
rotating.
Yeah, you'll
So
rotate.
you're still going to rotate
Everybody
every.
will all
Yes.
do.
So you're talking about per.
Yes,
Per,
correct.
yes.
Oh, okay, got it.
Yes, per scenario.
I got it. I'm good. I'll make it. I won't damage it. I promise.
she's also medical,
All right, why don't we get going then?
Okay. So now we will model and experience our follow-up discussion with the whole group. So I tend to do this kind of free form, but kind of asking people to sort of give first how was it in general, and then kind of going through in the different roles. But really, between you and your coordinator, you can decide how you want to structure this. But basically, what we want to do in this is primarily focus on just the process of it, the experience, not so much get into like what would have been the best answer for scenario X, Y, or Z. You can certainly touch on that, but those specific questions may certainly come up, and that's absolutely fine. But it's really more kind of the global experience of what it was like for people. So I will start off by asking the global question, was that useful, actually doing the practice session? Yes.
Yeah.
Good. Okay, that's what we want to hear. You're validating us. We appreciate that. Yeah, I think it really does. Like, it just feels so different when suddenly you're the one trying to think of what to say, or thinking of why did that person say that to me, thinking that would be helpful. So it does seem to be, as much as people resist sometimes doing this kind of practice. And I think this was the first time I managed to not use the word role play in advance, because that's so, yeah, it just sets people's defenses up. So, and I will also say, just from walking around and listening in on the groups, there is a vast difference in hearing mental health people do this than the general public. You guys, everything I heard was amazing and great. And hearing some of the groups that were, not that were in emergency response or just, administration, whatever, there's a real skill difference, and that is important to recognize, and again makes it all the more important that we do train people and give them that practice, but also help them understand the limits of what they should be doing. So thinking about this just when you were all serving as the helper, some of these questions, how comfortable did you feel? Did this feel natural? I'm guessing for most of you, again, you do this stuff day in, day out. We had quoting this, we had someone at one of the previous trainings who was a firefighter turned emergency manager who at the end of it said, I never want to have to do that again because it was so incredibly difficult and stressful, but I'm so glad that I know now what my staff might be having to do. So I thought that was a great kind of comment on why we train. Yeah.
I had a scenario as helper where there was a quarantine, so I had to call in by phone, and so I just kind of looked down. I was kind of looking towards the person to look down, so I couldn't read the body language and stuff, and I felt just flying blind a little bit.
Yeah, and that's why we wanted to include one where it was done, where the person it was being done by the phone. Right, and Mark, one of the groups he was doing that same scenario with, had them actually sit back to back, so they couldn't at all see that. And that's a great tip if you are overseeing that one. But yeah, I mean, it's so disorienting. We're so reliant on reading facial expressions and body language, and the person's making those statements, and you don't know if they're pacing around the room, if they're throwing pillows across the room. You just don't have those indicators, so it does make it particularly difficult. Yeah.
We might want to actually add that to the instructions on that scenario.
Yeah.
Have people sit back to back. That was a good idea.
Yeah, absolutely. Yeah.
Yeah, I was that group that was back to back, and it really was more. It felt like I was on the phone with him because I couldn't. The only thing I was able to read was his tone of voice.
Right.
And so doing that when he suggested we turn back to back really changed.
Right. Yep. So losing some of those cues we're used to relying on. Yeah. Great. And we should just point out some of the scenarios we know might have seemed less relevant or more overly specific. Dennis pointed this out. There's one some of you might have seen where it was an elderly woman who was resisting evacuating, and the helper was actually her home health care aide. That's not going to be one that most organizations are going to choose, but that was a request that we got from the
Home Health Association.
Home Health Association. So that's why, again, we have that vast range of them. But normally, it would all of the groups would be doing the same 3, and they would be chosen specifically for what their actual needs would be. So back to, so what was particularly challenging? So there, the not having the visual cues in the phone one, yeah.
Let's be a little creative with some of them because you don't know what all the resources are in certain
Right.
situations. Like when you were a mother and a child, where when we talked about it as professionals, we thought the child should be the subject, but it's the mother that you're speaking to.
Right.
So you kind of adjust it to work as best you can, but it makes you start thinking, how would I approach this? How would I be able to deal with this
Yeah, okay, so, right, who,
This was the
the-
shooting, the
Uh-huh.
child's friend passed, but the child was all right, and the mother was really concerned. The child
Right.
wasn't speaking, so you were
Right.
all in the gym at the time, you know, kind of going over things. So it was
right.
a lot at once, but you're, you know.
Yes, and that is absolutely one where I hope that any non-mental health professional, if that was selected for them, would immediately say, refer. This person definitely,
You want to go into a session, and it's like, how do I frame this
Right.
in the right way?
right, yes, that's,
So
again,
it's
one
very
of the more,
thought-provoking.
good, okay, good. Did anyone find yourselves doing that over reassuring that, you know, we'll take care of this, it'll be okay kind of thing? Yeah.
I didn't over reassure, but I caught myself. We did the evacuation of the nursing home to another nursing home because of a hurricane, and I think it was a hurricane. And I almost said that he would go back to his original nursing home, you know, after the hurricane, and then I realized,
don't know.
maybe it's not going to be there, you know. So I caught
Right.
myself. So.
Good, okay, good catch. Did anyone say something and then you couldn't believe you just said that?
Yes, I did.
Yes,
You
I
were
witnessed that
there.
one.
I found myself saying calm down, and then I caught myself really quickly, but I did say it.
Well, you didn't actually say calm down. You said maybe if we get you some water, that will help you calm down. So that was different than like, you need to calm down, young man. But you did immediately catch that, so that's good. And again, that's why we practice this and say it now in this setting so you don't say it in real life. Yes. Other thoughts just on acting as the helper? Did it feel realistic, like emotional, even though you knew it was a role play?
I actually found it easier when I just slipped into my role.
Okay.
Like I found myself distracted by making sure I got the checkpoints.
Oh, and
But,
that's,
like, I
you're
didn't
not
wanna
supposed
forget
to make
something,
sure,
but
yeah,
I can't
but,
imagine if I was not a mental health provider,
Right.
how difficult it would be
right,
to know those things.
right,
You know,
right,
to be mindful of the do's and don'ts and what's
Mhm.
helpful and to fight my own anxiety.
right.
Like I do that naturally because I'm a provider,
Mhm.
but people that are not are
Mhm.
not going to have that natural tendency. I found
Right.
myself feeling more effective when I just went with what
Your own
what the
skill
person I
set,
was helping-
right. Yeah, and that's great,
So,
but
I can't imagine
people
if they're
don't.
not. That would be
Right.
really difficult. So
yeah,
it
yeah.
illustrated that to me, like the vast difference.
Right, and even, I mean, with training lay people, for lack of a better word, it's not that we're training them to do mental health interventions, it's that we're training them to be compassionate and to understand what the person is experiencing and why they're acting the way they are and what they can do to help them. Dennis.
A tweak. If I was doing this to a group of lay folks,
Mhm.
I think having it could hold 100% be wrong, but I have a list of resources in front of that person. Because I think that would show them, because you would hope in the morning if they showed up at the gym, wherever, they would have that or know that there's that and, you know, whatever. I would certainly, for the role play purpose, at least have them something. They may never look at it, but no, there's going to be a list of resources. Because I came up with
Yeah.
a thing, well, is there, do we, we don't know. So I think make it seem more real for the thing, and I think it helped them refer and say, wow, those are great questions. By the way, we have a list.
Right.
Even just to have them get used to saying that may be helpful. For
Okay.
training purpose.
Sure, right, and for some of the scenarios more appropriate than
Yeah,
others,
yeah.
but that, yeah.
And of course, in a real response, you hope that list is there, but,
Right.
but
It might not
Well,
be.
if it's not, then yeah, we need to, then whoever's in charge of the
Right.
specific facility should at least, you know, some internet up, it's pretty
particularly
available.
early on, things tend.
Yeah, no,
tend
I
to be-
understand it.
tend to be
I know, it's a good question. I mean, like, I hear what he's saying, but it's a good thing to have in the training. So if they do get to a disaster site, what they're looking for is that referral list.
So, and I think part of this is these are folks who are part of some structure in the response,
Mhm.
and they may, they should know that there will be lists of
Right,
resources
just
and
at least tell them
referrals
that.
available
Yeah.
to them.
Yeah.
Right.
So having that in their
Right.
training.
Mm-hmm.
But,
Like
but
if
what
you-
level of detail and the kinds of referrals that you might be able to make may
Right.
not be able to do.
Right, okay, great. You had a comment?
I think agreeing with you, there's a flow, we all have a flow, because you do this. I think it would be really hard for a layperson to try and remember all those pieces. I
Mhm.
like the card.
Mhm.
So maybe if we're training people, that they get a little card that's like, oh, I did ask them if they want water. I did, like,
Yeah, yeah.
just as while they're doing the scenarios, it might even be something good to attach.
Do we have
Usually
enough-
we have that checklist.
Do we have enough for everybody? No.
No.
The Minnesota folks do have a
Yeah,
card,
yeah,
and we have a couple of them.
It's actually printed from their website.
Yeah, you can print it off their website.
Right.
No, and that's okay, but just for folks that are not
Yeah, no, good,
Right.
Because otherwise you start to second guess, oh gosh, I didn't do it, maybe I forgot, maybe, and you can always go back, like we all know, you can always go back and fix, but just to kind of ease some of their anxiety before they
Right.
go into the.
While also reminding them that the goal is not to check off everything on the checklist, but to think about what is actually
Right.
appropriate.
Right.
So that's a balancing act as well.
I
Yeah.
think at that point as well, it may be important to reinforce downloading the PFA tutorial
Mhm.
application, just so people feel some level of confidence.
Right.
Because if it's somebody who doesn't do this on a regular basis, they will feel lost, they will feel overwhelmed. But just taking a couple of minutes to go through the basic tenets helps people get focused.
Absolutely.
And
Yeah.
everybody's got a smartphone these days.
Right. Which hopefully will be working after the disaster. That's something of a question.
Once the app is downloaded, it's
Yes. Yeah.
One thing I think it's important not to step over is, and it hopefully it's available, and it came up in one of our role plays, if something looks psychological, it could be physiological. So if
Right.
someone can't breathe and they were stuck in a closet, I would, and I did, ask, was there any stuff around? If she's stuck in her cleaning closet and a bottle of chlorine mixed with ammonia, we may be having some toxic reaction. So I would, whoever you're training, I think they should at least look at this could be a physiological experience,
Right.
and we need to get I don't know what's in the site, but an LPN or someone, blood
Uh-huh.
pressure, the person's going to collapse in front of you, or your calmness, or your counseling,
Right.
because
Does
they're
not-
collapsing because they can't breathe,
Right.
is to nil.
Right, that's a great point. I mean, I emphasize the physiological being the water and the food and that,
Right,
but
there
medical
could be,
care is
again,
absolutely.
I'm trapped in a closet, a hurricane came, I was inhaling chemicals for the last 6 hours. They may be having some adverse toxic reaction.
Right, right. Great point. Sherry, you had a hand up.
Again, I think probably a couple questions back or comments back. Just familiarizing yourself with the services in the disaster response center, if
Right.
that's where you are. People talked about referring kind of other places and down the line, but at least familiarizing yourself with what's available on site that you can refer people to.
Right. Is there a mental health person on site? Is there a doctor or nurse?
Specific information.
Right. Yep. Yep. Good
And
point.
just to
Yeah.
piggyback on that, just to know what's available in the community before there's a disaster. So if you get into the situation, the phone lines may be down, but you might know ahead of time that, I know there's a food pantry here.
Mhm.
I don't know if we can reach out to them right now, but I know it exists, and once the communications are back up, we'll hook you up with that. Or I know that there's a support center over here that maybe, if we need to follow up with when the communication's back online, then we can do that. So not relying on just waiting until the moment and saying, I don't know
Right.
what's around.
Definitely. Okay. What about when you were acting as the client? Did you have any particularly helpful interventions where the helper said exactly what you needed to hear at that point?
Well, I could say the most helpful thing for me was when they offered to get me information or to do something for me. My thing was I was an irate worker that needed to get back to his job and worried I was going to lose my job. And she offered to contact them, and she assured me documentation would be provided. It was a national thing, so I shouldn't be losing my job. Like just that kind of
Right.
thing.
Right. Addressing those practical needs often is addressing the mental health needs that people have because it's reducing their stress and their anxiety and all of that. Yep, absolutely.
I think just the empathy and the validation were huge
Mhm.
to diffuse any sort of over emotion that was happening with the client at that time, and just constantly being like, that's appropriate, and we will find you the information. That in and of itself, I think, is a huge
Right.
piece of it.
Right. Yeah. I didn't mention it in my little brief PFA, but how many of you have heard the term "you're having a normal reaction to an abnormal experience"?
Yeah.
Okay. Don't say that because saying it's normal, it feels anything but normal to them at that point. But saying it is understandable that you're feeling the way you're feeling. A lot of people are feeling similar to the way you are now. Most people do start to feel better over time, but here's how to get some help if you need some help now or down the road. That I think is a really important message. So, right, it's validating. It's saying, yeah, this sucks. The position you're in is terrible, and it makes sense that you're feeling the way you are. Calling it normal, not so helpful. But yeah, great. Yeah.
When I was the client, there was a little bit of humor that was brought in there that was really helpful. I was saying I was hungry and I really like pizza, and so the helper said, well, I'm not sure sure if we can find pizza, but we'll find like the closest shaped pizza item that we can find to get you something to eat. And that was actually, kind of lightened up the situation a little while still attending to my needs.
Yeah, and I was observing that one, and the humor was used, but it was used late in the interaction, after rapport had been established, after a plan was made for contacting the kid's parents. So you don't lead with humor, but gauging when, at some point is that appropriate. That's a question that often comes up. Is it appropriate to use humor? Cautiously, kind of reading the cues from the person. Is it okay to touch someone? Cautiously. Ask if you wonder, especially if it's across genders, but sometimes people just need a hand on their shoulder, and that can be perfectly appropriate. Sometimes people will ask the helper to pray with them, and that can be challenging if that's not part of your own background. So, I would go with, I'm happy to, be with you while you pray or something like that. But these are the questions that come up, and of course, there's all sorts of cultural issues that we don't have time to get into, but these are sort of the stumbling blocks that sometimes arise for people. Yeah.
Just being able to watch my helper stay calm, even if I heat up.
Yeah.
Having just that neutrality where it wasn't overreacting, it wasn't underplaying, just stay with me. And that was super helpful. And again, all validation and reassuring and, resources offered were great, but I think it was that level of emotional stability that was very helpful.
Absolutely right. Again, you start to mirror that, and the calm can be as contagious as the anxiety can be.
Right.
So, did anyone have a silence that felt appropriate or felt uncomfortable? Not so much this one. Okay, but again, that certainly could come up. Okay. And did acting as the client kind of give you a better sense of how you would want to be treated and what might be useful and not useful? Generally?
It's tough. I think it's definitely easier to volunteer role if you're a provider and performing services.
Right.
You don't get as anxious being the person to help fix the situation.
Right.
You have to be the one in crisis.
Right.
It was actually significantly more difficult for me.
Oh, interesting. Okay.
To be like, oh my God, what do I do? I'm freaking out.
What was interesting, I observed that, and that was interesting, she had she was being an 18-year-old, and if you have an 18-year-old girl, that she's going to be.
Not the phone.
Yeah. I should be more upset, right?
So it's just the balance of, she didn't want to overact.
Right.
But that's really what you would have gotten.
Right. Yes. Oh, Mark also made another master tip. If you are doing the role play, and especially if you're the client and you're about to start laughing, to crack up, to break, put your head down and pretend you're crying until it passes. That was a really good one because it helps your partner stay in role. Okay, and then just as observers, anything? Was it useful to be an observer?
Yeah.
Okay, so why? What was helpful about that?
I think sometimes, again, you're so used to it, and it's not that you have a script because you respond to people, but there are things you certainly say consistently, and someone else observing what you were saying and how you're interacting was really helpful because there were things that they said, that was really good that you didn't say that. And I went, I don't know if I planned that. I think that just happened. But just an awareness, like an increased awareness of what you were doing in the moment.
Okay, good. So sort of confirming what you did right as much as anything else.
Also making you aware of things that you may not have thought of.
Okay, that you just did naturally. Great. Okay.
Language.
I think it's just a good contrast to when you're in the other two, roles. You're in the weeds or whatever, and when you're an observer, you get the gestalt of it and how to step back and see how the whole thing plays out. So it's a nice contrast.
Right. You're not so focused on what the hell am I going to say next that you can actually pay attention to all of the full interaction. Yeah. Right. Great. Yeah.
And you're also able to observe other techniques.
Right.
And see other people
who
may come from different disciplines.
Yeah. Right. Exactly. I wouldn't have thought of that. Not to say that. Yeah. Great point. Right. What about our master trainers?
I observed did very well. They didn't go overboard
Good.
in terms of the role plays. Just the skill level in terms of what they were saying and
tell this was a seasoned group.
Yes, definitely.
So definitely all the skill set was there as providers and stuff. So I am interested to see what training would be like when people are not master
Yes.
levels and above, or
Very
some
different.
issues in training.
So we can tell you that someone said, we know we're not good at this,
Right.
but we know now who we can call.
Right. Marketing.
What they said, you can tell everyone with great experience
Mhm.
and seem very confident in these respects.
Right. Okay. Any other sort of general comments? And I'll just do a few sort of facilitation tips briefly. Any thoughts on the specific scenarios? We got a few comments on those, but other, yeah.
I just thought that having the one over the telephone was challenging, but it was really good because it did make you, not rely so much on seeing that person,
Right.
Face to face, even though for these persons they're here face to face, but remembering what you can do to provide some sort of comfort and assurance and reassurance, and that person is not there. You can't even reach out a hand or make a face-to-face contact. So it kind of made me really think about what can I do to make a connection with this person. So that was really challenging, but it was good experience.
Great. Okay. Thank you.
I'm sorry.
Sure.
I was just gonna say the diversity is, I like the diversity of scenarios.
Okay,
Because
good.
For various people, some are gonna be hot, some are gonna be cold, so
Right.
having that mix is good.
Right. Okay. Great.
It was triggered by our scenario. Just curious, what's the police actual response if you're a police agency and you're going to people's homes because a hurricane's coming and the governor, ordered evacuation? What actually happens if that person, that 92-year-old, says, I'm not leaving my home, I'll ride it out? What does the police actually do, assuming we're training a first responder in psychological first aid, who's also now knocking on people's doors saying you gotta leave, whether they're police or not? At what point do they move on to the next door, or what do they actually do in that scenario?
Yeah, I mean,
They have their own protocol where they, like, if the person doesn't want to leave and it's a safe
I mean,
situation.
just to judge from the recent hurricane and all the coverage I saw, I mean, you can't force people to carry, tie people down and carry them out of their houses. So, a point to make to them is you're putting others in danger because they're going to have to come and rescue you. That may be, if they don't care about themselves, maybe at least they'll care about somebody else. But
They didn't go.
Yeah,
They
but-
did not go
but-
this time. They
but-
were told they would not be able to send them out.
well, at a certain point, you say nobody's going to be able to come until the storm has passed.
Right, and then the news coverage always seems to validate it because now it's never as bad as it was, except when it is. They say, I told you I'd be fine, except the one time it's not.
And those people you don't generally talk to.
I think like Rockland started a pet shelter phone Katrina, because that was a big reason why people didn't leave. So I think that, being able to have information such as that to put out to people. Is really
Right.
important.
That's a much more recognition that people won't leave their pets, they won't evacuate without them. So, yep.
Well, that's like a slippery slope. I kind of feel like I think it's great that we have this, but I think it's kind of like I'm not necessarily going to think everybody can jump into the scenario of doing this. Like I'm not going to become a nurse suddenly overnight. So I think it's kind of hard to think that anybody's going to walk in and be able to make people calm.
Right. It's more, absolutely some situations are going to take, escalation to a higher level. But I think that, with PFA, so much of it is just building people's confidence in their ability to connect with others. So even if, you're not going to be able to fix every situation or handle every interaction perfectly, just believing you have some kind of skills seems to have value.
I think, so Hurricane Irene, I was supposed to do a shelter. They called me as a volunteer to the shelter, and I showed up and they had me answering the phones, and I was like, okay, like I knew in the shelter there'd be somebody else if I needed a question, and I was like on the phone, so just even that little bit of having some guidance about, what I should, helping them focus on what they would need as a person without a mental health background would be extremely helpful. And then, as people said in the other trainings, is that they now know that they shouldn't be the person doing that.
Right.
They pulled in with people with that strength.
Feedback. So again, just, if you are leading this discussion, I think we want to validate it's really hard and it's, uncomfortable sometimes, but that again is why we do this practice and build up that confidence. So just a few sort of random tips. A lot of these are more organizational. We do, like the way that we had the packets of handouts ready to go, I strongly recommend doing that, because if you are trying to collate stuff and at the same time you're forming the groups, you can see how chaotic it gets when you start moving people around. So that's just a recommendation for your own comfort. I said this before, some people are going to resist, and we need to kind of respect that, but also encourage them to. Try not to use the word role play. That definitely gets people's guard up. And I think I covered this sufficiently, but hopefully the scenarios that were selected are appropriate for the audience. But I think, especially as mental health people, we might assume a higher tolerance level for some of these situations than a general audience might have. So we're used to thinking about horrible things happening to people. Not everyone is. So just even imagining kind of being in this situation might be very difficult for people. And watching out for people who are not just acting overly distressed, but who are not acting, not pretending to be overly distressed, but actually are, and responding to that if necessary. And back to they are acting overly emotional. I made that point before. Talked about this before, just reminding people there will be that discussion. The third point, this one gets a little tricky sometimes. If people have experience and that can enrich the conversation for others, great to have them incorporate that. Sometimes people want to make it a therapy session all about their own disaster experience, so you need to kind of set limits on that. Or just having one person dominate. Every group, there are the talkers and the non-talkers, and trying to kind of balance that and not have the more experienced people make the less experienced people feel inferior or something like that. Just kind of group process management in general. And then networking, we can't emphasize that enough. If it's everyone within one agency, maybe that's not such a big deal, but if the training is combining people who are going to end up responding together, this is such a good opportunity to get to know each other. So that's why we started doing the name tags. That can be very useful. If you have a small enough group, start it off by having everyone introduce themselves to the whole group. Not always feasible, but at least when you split people into the small groups, at least having them kind of exchange names and roles and all of that is useful. And that's it for me. So just any questions or comments on before I turn it back over to Gus? No? Okay, good.
Great, thanks, Carla. So I think that really concludes the bulk of today's session. I think there are a couple things just to mention. They're in the evaluation forms, and when we're done here, please take a few minutes and just finish filling those out. There are questions about your willingness to be on a list to at least get calls to come assist with these. So to the extent you can answer that, yes, that's great, but we understand if you're uncomfortable with that. And the other way to just, so if you are willing to do that, and I know the November 7th date is coming up pretty quickly, but if you are able to do that, you can either indicate that by sending us an email or actually going on and registering to attend that training, and we'll cross-check your names with that. But so when you do fill out the questionnaire, please indicate your willingness there. And those names are not going to be published anywhere on a website. They're going to be held at the regional coalition sites, which are the state health department offices. And so when they get a hospital or county that wants to do a training and wants a mental health professional, they'll have the list available for them to contact and see if it's able to work out. So that's really how that's going to work. We would also like to track if you do provide technical assistance. So Mary, is there a form to do that?
But also, I mentioned a couple of those scenarios. The exercises for the Department of Health have come out, and local health departments either are going to have to do a COVID dispensing exercise or a quarantine exercise in February and March. And so those scenarios are, and one of the objectives is that they have to identify some vulnerable populations, so there may be some mental health issues. So it would be a great opportunity for you to get either involved with providing the mental health
So I think we'll certainly let the counties and hospitals know around those two particular scenarios that you folks are available if they want to combine a training, for example, on that topic or whatever.
And we're also looking to see that maybe you might be able to help if they get trained in PFA to see if they're actually doing it at a pod exercise and be able to.
Right. So one of a pod is where you set up to do vaccinations or hand out medication, and you typically need to have people there to answer people's questions and counsel them if they're concerned. If it's if you're in the middle of some bioterrorism event, people may be very concerned. So to have people there to talk with people, PFA should be one of the roles that people participating in a pod would have.
So if somebody does contact you to participate, if you want to keep track of it, that'd be great. We'd really like to do a follow-up survey at some point next year and see if there's been any.
So I think there is a form in your packets. If you do get called, we wouldn't necessarily know that, but if you can just record that. And as I say, this grant is active until August, but I think this email will stay active even when the grant is over. So.
Has the Department of Health in the counties been? I don't know. Is anybody here from Putnam County Department of Health?
They're signed up for the.
So the Department of Health if they didn't have a mental health person on staff, they wouldn't necessarily come to this.
That's a missing in some level.
Well, but many counties don't have a mental health. So today's session was really focused on people with mental health background.
Exactly what you just said. I mean, I'm part of Medical Reserve Corps, and I had those meetings yesterday with two of.
So I think Putnam, they're signed up for the 7th to come, so that somebody who's the training coordinator at Putnam County is going to come.
Okay, I'll make sure that happens.
Yeah.
Okay, cool.
And when you talk about vulnerable populations, I would really encourage you to include the
Developmentally disabled population.
Yeah. WDD and all of nature so silent.
Yeah.
No, I think quite a few pods that they have included.
Developmentally disabled included pod. So that's a question of whether we might want to have a scenario based in that kind of a setting. I don't know.
Good point.
We can or with that kind of a population. No, good point. Good point. So yeah, I think we will be doing a follow-up survey of the counties and hospitals probably spring, early summer next year, just to see what happened. So that it'll be helpful if they've been able to do that. And we're going to be out there beating the bushes to have them do trainings and hopefully contact you in the process.
And we want to reach out to the MHAs around the county too, around the state rather, mental health associations.
Mental health associations.
Do an amazing amount of peer supports and peer this and peer this. They have all sorts of social activities, but I don't know if anybody's there trained in psychological first aid.
I believe I sent it to the Hudson Valley.
Okay.
The Mental Health Association. I think, So as much we can get the word out, that's very helpful. Yeah, good point. Good point. Anything else on this slide, Mary? I think those are the points. So again, we really thank you for taking time today. If you would take a look at the follow-up questionnaire and fill that out. And we are interested in any additional feedback you might want to provide. Any suggestions are welcome. And we told you about the CEUs and the travel reimbursement. So
you have to sign out, right?
Yeah, you need so you need to sign out in and out on the sign out sheets to get the CEUs. I want to thank our 3 mental health master trainers for coming today. Thank you, very helpful. And any last minute points or questions, comments? Great, so we'll end a little bit early. Thank you all very much.